So Eric Topol and I are up here now, and you're saying that, yes, you like this idea of tattoos, just to go right into the continuity here.
Well, I think a lot of that work has been pioneered by John Rogers, University of Illinois, and it's actually pretty remarkable how many things you can sense: electrocardiogram, EEG. Now you can get chemical analytes. It's something that is very easily integrated to the skin. Is one of the things. Admittedly, there are issues about wearables, and tattoos are just another version of that. But it's one of the many tools.
But let me just then back up to introducing you. Eric is one of the great pundits and thinkers, a doctor who is a cardiologist who is giving tremendous thought to what's possible if we step back and look at healthcare as an integrated, digitally oriented system. His most recent best-selling book is The Patient Will See You Now. He's written a ton about this stuff. He is really such a great thinker about it and inspiring to a number of us. We're honored to have him. So, and I really think it's great to have you at the end here, because you've been listening to everything. I'd love you to comment on anything you've heard and tell us, again, going back to my opening comments about making this into a movement, what are the prospects of that? So, that's maybe what I want to talk to you about, and anything else that you want to focus in on, because you have so many interesting thoughts on this.
Well, we get to the movement thing. That'll be interesting. But I guess, too, I heard a lot of great stuff this morning. I think it was really very interesting, great perspective. Obviously, really, the cognoscenti in the room here. But one topic I think that's setting the stage for this transformation is this ability to digitize human beings. And we have lots of different ways we can do that. There hasn't been much talk about genomics.
Yeah, I wanted to get into genomics
because it hasn't
come up much.
There's a paper that just came out this morning from Harvard, which basically showed in 2 very large cohorts followed over many years, you could predict cancer and heart disease with 4 to 13-fold risk with no family history. So that tells you about
just from genetic information.
Yeah, just from genetic information. So this whole idea that sequencing is not going to be helpful, this refutes that. But so genomics, sequencing, we talked about imaging, all these different tools that we didn't have before. And all these tools generate data that is eminently portable, and moreover, that it can be, for the large part, consumer, patient, person generated. So that's, I think, the basic part of the foundation here. Now, the thing that really gets me going as far as the data story, which you touched on many different ways this morning, but owning the data. It's not enough accessing, it's not enough controlling. It has to be owned. And let me try to make that story with a little more color to it. But firstly, it is owned today by doctors, hospitals, and health systems.
The data about you.
Yeah. The only place it isn't is in the state of New Hampshire, and they don't even know that they actually legally own the data there. But the reason why everyone has your data, whether it could be mobile apps, it could be data brokers, it could be, you name it, everyone except you has your data. And you paid for it. It's services that you paid for, and you need it. And this stuff about fax machines and all this other crap. But the point is the privacy security is porous. I mean, over 100 million Americans have had their medical data, EMRs, hacked this year, in the past 12 months.
In the past 12 months.
And less than 5 million have ever accessed their electronic medical records. So we have a terrible mismatch, and that has to get fixed. And that can be fixed through such solutions as blockchain, personal cloud. We have technological solutions, but we also have to have a governmental solution. And you, in your opening remarks, you got to that. You said that you don't think that in the new administration that's likely. But actually, I've talked in a bipartisan group of Congress, and I was surprised how strong support there was among Republicans also.
For what exactly?
For data ownership, a civil right, a new civil right. Yes.
That's regulation, baby.
I know, but it also is decentralization.
All right.
And right now,
I hope you're right.
The government is our biggest payer, and it actually fulfills that the data have to be shared, obviously. And this whole idea about the joint stewardship and all that sort of thing, that's fine. But that's a really important thing to watch over the years ahead. The reason to watch it is people are going to be generating more data than was ever in the cockamamie electronic medical record. And soon that mass is just overriding what is this we already, I think, was beaten up, this EMR, which is, really got a lot of shaky stuff because of the wrong purposes for what it is, created for. I mean, there are important things, to echo one of the other physicians, that you need, as a physician, you need that to refer back to when the patient comes back or you're making, recommendations, whatever. But for the most part, the way it's set up today, Epic, Cerner, Allscripts, and these various proprietary platforms are not going to last because they don't take the person's generated data. They don't have sequence. That's going to be more and more the case, and over time, either they will erode or they'll have to adapt.
When you see a possibility that we could move towards a legal right to own your medical data, is that partly because of the cyber threat environment that maybe has pushed the awareness of some of the risks, and maybe there's some idea that somehow it could be beneficial for the individual to own it? I could see some logic to that. Is that part of the reason why it might be happening?
You actually hit on this with your tech background. So everyone, if you talk to cyber security experts, the gurus in this, the first thing you do to prevent hacking and breach of data is to decentralize it.
Right. Well, also, people are going to be much more concerned about protecting it if they own it and they control it.
Exactly. And it's their right to own it. I mean, the fact is, even if you, right now I'm involved with this precision medicine initiative, which hopefully is going to hold up, it's an Obama thing, so hopefully. But the point about that is, everybody's really fixated on the EMR. Well, the reason that's a problem is because there's a lot of EMRs out there. I mean, you don't just go to one provider and have that electronic record. And we've already talked about the lack of interoperability and all this other thing. So the problem is, you as a person, and that's true person-centered, which that concept was brought up in 1969. We haven't even come close to that. We're so far away. But that should be the way to decentralize the data and give it to the rightful owner, the person who has the most vested interest, and that person can quickly, electronically share whatever they feel is appropriate to whomever, whenever, and that's the way it should be. Not the paternalistic, doctor-controlled, the thinking that patients can't handle the truth. That's what we're in that right now. We got to get over that because they can handle the truth. In fact, indeed, they need to. And so many studies have borne out that people do very well having their medical data whatever is in there.
Wow, that's great. I'm glad you're confident that that's a movement that may be beginning.
Well, yeah, it may take a while.
But let me ask you, going back to this movement question, I mean, this is a room of very influential and engaged people in this universe. What can we do collectively to push for that likelihood to be greater?
Yeah,
I think there's hardly going to be any dispute that that would be beneficial.
Yeah, no, and I think, Rick commented about that this morning about, is it coming from the edges, from the inside? Where is this going to come from? Because eventually it has to change. It has to adapt to a whole new everything, really. I mean, this is the ultimate creative destruction of healthcare and medicine that is inevitable. It's just a matter of, is it in this decade, or is it going to be forestalled for quite a long time? Now,
or could it come from other countries that are more behind and leapfrog by, maybe India or something?
Oh, I think that's happening.
And shame us into doing it eventually.
In some ways, that's already happening. Yeah. We can get back to that. But so this week, I had a really fascinating meeting, which I was kind of struck by. So there's this group, which I had read about back in February, called the Health Transformational Alliance, HTA. And the CEO of that is a guy named Rob Andrews, who actually was a congressman for many years. And he has assembled now, just since February, there were 20 companies. Now there's almost 40. And their goal is to get to a very large proportion of self-employer large companies.
So these are employers who have a lot of insured individuals.
Yeah, I mean, they've got already somewhere several billion, over 25 billion of healthcare costs per year, and they've moved really fast. They doubled everything in just 8 months. So, and he also told me the various companies they're in discussions with. But if you just look at the list that's out there, including the likes of IBM, Coca-Cola, I mean, really big companies. So these companies have the vested interest in fixing this mess. And they're not getting the response from Aetna and Blue Cross and United. And so what we're talking about here is not about electronic records. We're talking about that they demand the medicine is changed of their employees and their families. So for example, they're working with this Geisinger company called XG. It was a Geisinger derivative. And Steele, who was the CEO of Geisinger, moved with Earl Steinberg to form this company called XG. Now, why is that important? Well, they're starting with diabetes, back pain to avoid spinal fusions that are unnecessary, and all sorts of other things. And the third one, these are just the first three that they're rolling out to all these employers. And all the employers are sharing all the medical data from all their employees and families, not to help the hacking and breach problem. So they're going to have to be very careful of that data. So we're seeing something bubbling up from the big companies in this country, which
in order to create a movement, in effect.
That's what.
It's not a bottom up of the type that I was thinking of, but yeah.
Yeah, I had met with some of the large employers. I mean, AT&T, GE, IBM. I kept hearing the same story. We're spending several $1 billion a year for healthcare. We can't do this. We have to come up with a new way. And now they are hyper motivated, and this is the only thing I've seen that gives that power of lots of large companies working together for a common purpose. And they pay, a one-time fee to join this thing. And for these large companies, it's pretty nominal. So we'll see what happens. That's one way. Now, it could be any one of these large companies just breaks out on their own. That could be an important
and how would that happen? To do what exactly?
Okay, well, there's a list of 100 things a company could do today if they decided to do it. It works much better in companies that don't have unions, that actually have control of their employee base. And I think 170 million people in America are employee health connected. That's how they get their health care. So it's a very dominant part.
Retiree medical care.
Yeah, there you go. So what we're talking about here is that could be the way. I think there are some large companies that are part of this HTA and some that are not, that are right on the brink of saying, we're going to do all these things. They're all evidence-based, and we could go through certain examples to show how they're markedly cost savings, but there's a list of hundreds of this. I don't know, you haven't heard probably of this Choosing Wisely initiative, but it was done by all the medical societies. And it says all the things that we shouldn't do anymore, which are being done every day.
Like, just give an example.
Oh, like you shouldn't do a CT scan for this, or an MRI for that, or you shouldn't do a spinal fusion. Hundreds of things. Every medical society essentially gave away their things that should be considered taboo, which are being done every day in this country.
Wasting money and possibly causing more ill health.
They admitted it, but you see, there's no teeth in that. This was published by American Board of Internal Medicine Foundation, and across all the surgical specialties too. And the problem with it really is that there's no teeth, and so who's going to make the Choosing Wisely come alive? And this was volunteered with evidence from the medical community. Okay, so that's only part of the list. We have a lot of. Somebody commented about the Tesla. And I can't afford a Tesla. Okay, I get that. But we're not talking about Teslas here. We're talking about cheap chips. We're talking about stuff that you can buy, like an electrocardiogram for your smartphone for $69 or less.
Well, you mentioned this idea of testing for the genetic information that would show susceptibility to 100 different commonly used drugs, and you said a $10 chip could be used to test everyone, but we don't even do that.
It's unbelievable.
To avoid unfavorable drug interaction.
Yeah, no. Over the last several years, we have amalgamated amazing amount of drug DNA interaction knowledge, unequivocal knowledge that we don't use today in medicine. And so you could make a chip for a couple of dollars that would screen all the known FDA-labeled genomic variants, so that people don't take drugs that are going to potentially be serious side effects, some even associated with fatality, or drugs that aren't going to work in them. I mean, that's just remarkable. So that's just an example of, a big employer could say, we're going to have the chip made, we're going to screen everybody in our employee base, and they're not going to get drugs that don't work, and they're not going to get drugs that cause side effects. And we're talking about one of the top 5 leading causes of death in this country, of medication errors, medication side effects. It's a serious problem that's not been adequately acknowledged or addressed.
Wow. I don't want to be greedy. I want to share my ability to interview Eric with you all. Who has some thoughts, questions, comments? Was that your hand, Jim? Or were you scratching your head?
Yes.
Oh, sorry. Well, okay, please. Identify yourself again.
Orunduti Parmar, I'm editor of Med City News. Just wondering, given what happened last night, there's certainly going to be some changes to the Obamacare model, which I feel sort of accelerated this move to adopting technology to reduce costs. So when that change happens, and who knows how long it's going to take and what shape it's going to take, do you think the focus on the costs and the use of technology to sort of provide care in a different model outside the hospital, is that going to fundamentally change, or has that horse sort of left the barn?
No, I think the horse left the barn if we accept that Moore's law will come to medicine. And this is something that I still find remarkable, because these chips, whether you're going to do DNA interrogation, or whether you're going to physiologic monitors, or you're going to do your smartphone labs, instead of the ridiculous amount of costs of going to a central or hospital lab, all these things can be done so incredibly cheaply. And so we haven't taken advantage of that. We've rejected it because we're stuck in this big ticket item, incumbents that rule the roost, paternalistic. Most doctors don't think that patients should be able to do these things on their own. They reject the idea that they could have algorithms that interpret their electrocardiogram, interpret their child's eardrum possible infection, interpret their sleep apnea data that they do in a $1 add-on to their phone. That's not only challenging control.
As opposed to a $4,000 overnight stay in the hospital.
Yeah, I mean, this is challenging control of doctors that they have enjoyed, since long before Hippocrates, actually.
Do all the doctors in the room agree with that? Who disagrees with what he just said? Anybody?
Historically.
What?
Historically true.
Okay. Oh,
So just to comment to that point, with the new doctors being trained now that are in their 20s, half of their life has been connected. Aren't they going to demand these things now?
Yes, we have the best hope, but if we wait for them, we may not, some of us may not be here. So that's the problem. Why do we have to wait when every day there's people that are suffering unnecessarily and wasting? I mean, we're talking about over $1 trillion a year in this country, unequivocal waste, because we're not adopting the technologies. And this other thing about, technology depersonalizes medicine, that is not true. What is true is the electronic health record has been a veritable disaster with the keyboard and not connecting with the patient. But that's not technology. That's anti-technology. That's a farce.
wait, so instead of a keyboard, what should it be?
Oh, Prakash, where is he? He mentioned it.
He's outside.
Oh, okay. You have natural language processing of the whole interaction.
Just record the whole thing.
Yeah. And the doctor's transparent about what, the interpretation. It's all there and discussed, like it should be openly. That is then transcribed, edited by the patient first to make sure it's accurate, because it's amazing how much inaccurate stuff is in the medical record when you finally get to it, if you can get to it.
Which you can.
Yeah, and then it goes machine learning for the doctor, so the doctor doesn't have to put a lot of time into it to make sure that it basically every time he does one of these, it's just getting smarter and smarter about him signing off on it. And we have no keyboard. Everything is in the transaction. And then, by the way, that's already being done in telemedicine. That's one of the attractive aspects of telemedicine, because it's a digital encounter and all that can be archived.
I was amazed. I just got a new GP in New York City. I'm 63 years old. I've had the other doctor who was retiring for 30-some years. The new doctor did not ask me anything about my previous records. He didn't even want them. I mean, I couldn't believe it. I mean, I realize next time I see him, I'm going to say, you got to get my records, for God's sake. But that just is so astonishing. Does that astonish you? Is that just the way it is?
Well, if you're healthy, he says, have you had any medical problems? And if you say no.
Okay, well, I told him about a few little things, but come on, I haven't seen this thing. There's like reams of paper about me. They should at least be curious to know where it is, don't you think?
Yeah,
Another doctor.
definitely.
Get
So
another doctor.
No, I mean-
there is a serious problem with that, and if you are on the bleeding edge of interoperability, which we are, and you can pre-stage the fetch from other healthcare organizations based upon an appointment schedule, and pull in all the continuity of care documents, which include the problems, meds, allergies, and immunizations from anywhere someone's been seen, and you can put that in front of the physician for an encounter. Let's say someone comes in for bronchitis and they have an appointment, and you pull that in, you're going to see so many conflicting diagnoses, so many conflicting and outdated medications, so many conflicting allergies and conflicting immunization records, that it actually becomes a very low signal to noise ratio. So that reflects the fact that we're at an inflection point between an era where data didn't flow freely and an era when data does.
So the
flow
data is
freely.
just so bad they'd rather not have it, is what you're saying.
It's not necessary that it's bad. It's the amount of time it takes to rationalize, reconcile, harmonize, process, analyze, and apply the data.
One
is
thing
so
I noticed
long.
was he was giving me new immunizations without even asking me whether I had them.
Right. I'm not.
I don't think this is a bad doctor, by the way.
I'm not arguing for the virtue of what I'm describing. I'm just describing where we are in that inflection point.
Okay.
5 years from now, hopefully, there will be much better ways of rationalizing, normalizing, interpreting, using the machine to actually generate something that is quickly usable for that physician to help in your care. But we're not there yet.
We could be, though. We could be, but you know, a lot of this stuff is just summarily dismissed by the incumbent health systems and physicians. I mean, we have a lot of resistance. Reimbursement was touched on many times this morning. That's part of it. Control is part of it. Education and training is part of it. But the resistance is profound. The reason why this is the last frontier, and the reason why only now, you know, Apple and IBM, Qualcomm, Microsoft, Facebook, all the rest of the tech, Amazon eventually is going to get in here, is they've realized this is the last frontier that's going to go through the biggest change. But they know it's not just the FDA regulatory, it's the resistance of this sclerotic medical community, which is, you know, a very controlling. And it's going to be interesting to see, you know, even in the political front, how do you repeal Obamacare? Because it's those same parties. It's the insurers, it's all the different lobbying forces, how that's going to happen, even though it's been sworn it's going to happen. Because it's the same medical community we're trying to change right now with this advent of remarkable technology that the rest of the world, every other sector is adopting, and we are largely resistant. And it's reflected by, for example, doctors today. 70% of American doctors today don't want the patients to get their office notes. That says a lot right there. And that's been constant for years, every time it's been looked at. And there may be projects like Open Notes, that's wonderful, but that's a tiny minority of people. And you know, if you say, I'd like to get my copy of my notes that I paid for my visit about my body, you can't get
But is that about a fear of liability primarily?
Oh yeah, no, a lot of this, that's another part of the control. The doctors don't want to email, don't want to communicate with their patients through today's technology, because partly they might have something in that email that makes them liable. But you know, we already do know that if you have a good relationship with patients, it doesn't matter what you put in your email. If you have trust, they're not going to sue you. But there's not enough time to actually establish trust. We've got 7-minute visits. How much trust can you, 12-minute for a new patient? That's going to engender a lot of trust. You know, that's a real problem.
Right on the point around the adoption cycle in healthcare. So today, we put billion-dollar machines in the air with hundreds of people flying over millions of citizens, and they fly by themselves.
Yeah.
We were able to do that because people were motivated to make that happen. So data-driven machines exist today. We're about to do that with autonomous cars on the ground, driving through our neighborhoods. So the idea that someone in healthcare has to look at the data in order to interpret it, for a lot of stuff, yes. But for a lot of other stuff, no.
Right.
And if we can, you know, for an autonomous car, there's no one sitting in the back of it with a remote controller or leaning forward and popping the wheel this way and that way based on data. It's data-driven. It's running itself. And so we're,
as best we can tell, far safer than human driving.
Yeah. And that's, no, wait. I love all these people, but you've said, well, do you go by Bob, by the way?
Either's fine,
Okay.
Bob's fine.
Bob, real quick, and then I wanted to hear something from Walter, whatever, but Bob first.
So getting back to your point about
and John.
unnecessary tests being ordered and resistance to that. So I'm curious why you think insurers haven't clamped down. And for physicians, it seems one motivator is physicians end up with, $200,000 of debt or whatever from med school, therefore they order lots of fancy tests. I mean, how do we tackle that?
Okay, well, the insurers, I think they get it now, so they're going to try to differentiate from one another by going into this, major change, cost-cutting technology, but they're slow and moving. These are mammoth, organizations, and so they do it in tiny pilots, and they take a long time, and that sort of thing. As far as the debt issues of education, I mean, education is the only other thing like healthcare, right? That is just so far behind, and all this replication of transferring information and knowledge. That could also go obviously through a much more economical model that wouldn't result in these ridiculous amounts of debt. So, hopefully someday that will be seen as well.
Walter, did you have anything you wanted to chime in?
Well, first of all,
Identify yourself.
what Rick says is interesting, but the planes. It's also interesting that 94% of Americans do not believe that computers actually fly these planes, and we actually participate in that by putting actors with hats, like pilots who are only able
Actors with hats.
but cannot touch the machine or something would happen. So you see, if we are, and this is the time now for
Unless it's
rural
solid.
health, for bringing machines in, because basically we have now 1 million genome sequenced between the US and China and 18,000 interpreted. All the rest are waiting for an interpretation, which will be between 6 and 8 months. So the historical rate of these genomes, by 2023, if they go on like this, and the price is going down, we'll have 1 billion genomes sequenced. Yeah, we're running out of humans. So apart from the fact that Hal is going to Mars, so we're running out of humans. It's time for the machine to take center stage, because it's basically number crunching.
Yeah, and
That's a nice way to say it. Thank you.
And that's another point that both Walter DeBauer and Rick brought up, about machines. But what unfortunately we do in medicine, we always talk about it's the man versus machine, and never really see the synergy that really exists, because the machines can do so many things so much better. And I think this is something that is so largely missing. It's tied into that unwillingness to change and the loss of control, and even for a lot of doctors to think that a machine could do part of their job better it's heresy.
Well, you will all shortly receive a copy of the Techonomy magazine, which we haven't yet distributed, but there's a pile for anybody who's not going to be at the conference this afternoon out on the table. And at the bottom of that cover, it says, "Towards a world where man and machine, people and machines converge."
Yeah.
Because we have concluded, not just from our work in healthcare, from our work with Accenture around AI and all kinds of other stuff, this is happening whether we like it or not, whether Trump's elected or not, no matter what. The computers and people are moving closer together in ways that are so complex and so exciting and so interesting that it cannot be stopped.
Yeah, just another example, we have a piece coming out about what we call the information specialist, and this was touched on this morning. It's been shown by AI. You can read pathologist slides better by a computer. You can read x-rays and radiologic images across the board better by machines than by expert human specialists. And so you start to wonder, IBM keeps saying, well, we're not trying to take the place of radiologists or pathologists, but the tools are there. These doctors that are in those specialties that practice in that way, they have to start thinking of what they're going to do next. In JAMA, we try soon to be out to discuss where medicine, that's just an example. But yes, this convergence is happening, and a lot of those things, for example, when it's been unequivocally proven, you can do better certain activities, tasks with a machine than a doctor, it's going to change. It has to change.
Okay, John, and then we're going to have to wrap shortly, but I want to hear a few more voices before we do. Go.
Yeah, I just want to agree with Eric that battling the ossified infrastructure as it is really painful. So I led at scale the release of lab results directly to patients simultaneous to them being released to doc. I led the email initiative. I led the health record. I've led the open notes. I have led all of these at scale and met the resistance he's talking about, even within an enlightened organization. What I'd like to say is we have to be, I'd like to add to that, because I do agree. What I'd like to add to that is we need to be careful not to blame the victim. Because if you look at the fact that 50% of primary care physicians today are burned out.
Right.
They are burned out with too much work and not enough time already. And we come to them and say, hey, I've got this great new stream of data coming from a body sensor. How would you like to see it?
Yeah.
It's like, no, you know, so what we have the luxury of doing in our institutions, we can take doctors out of clinic and they still get paid when they're not seeing patients. And we help upgrade their skills. And we have had more than a few doctors, much more than a few doctors, break down and cry and say, I was ready to quit medicine. Thank you for saving my career by helping me get through my day, without layering on this other stuff. We are in a crisis mode. We're overregulated, and we have a tremendous amount of time pressure, especially on primary care, but in general. And so I want to say we need to be very careful not to blame the victim in this ossification.
Yeah, this is a really critical point you're bringing up, John, and that is that the fact that there is this burnout.
Yes.
It's not just among physicians, and it's profound.
It's not just in the US.
It's also again, among nurses, as documented this week in the Wall Street Journal.
Right.
It's across the board.
Yep.
But part of that, and by the way, if you look at every city in this country, and in fact, the labor force for healthcare is higher than retail. I mean, it's unsustainable, just the labor force, no less. But if we use technology, we can actually reduce the burden for doctors, nurses, across all healthcare workers. You know, that's a big. You've done it at Kaiser to some extent. It can be done even more.
We have much more work to do than we've done so far.
And it's a leading edge sort of institution. There's only a few that fulfill that model. So the physician burnout is central. We have a potential solution for this and for the doctor shortage and all this sort of thing. But again, it's just we're getting in the way of our own future. That's really the impossible part of this. One last thing, just to bring it back. You asked about how can we get the movement going. You know, it could happen if it doesn't happen from companies. It could actually happen at the consumer base.
Right.
Their power, if there was a health spring mounted, you know, we're not going to take it anymore. You could see that in the next couple of years. Yeah, it's not. We don't want to rule out the power of the public.
Speaking of Health Spring, can you talk at all about your interaction with Zuckerberg, since he's going to be here tomorrow, and that might lead me to some questions to ask him, or not that I don't have a list this long already, but you said you spent some interesting time with him. I think it might be a fun way to end to hear you tell about that.
Well, he was very interested in this project we're working on, actually a Qualcomm supported project, which is a sensor, it's a nano sensor put into the bloodstream to sense a heart attack days or a couple of weeks before it actually happened. We have a gene signature, we have a sensor, and now we have to go through an incredible amount of regulatory issues to prove.
This is what you're working on?
Yeah, and Mark wanted one implanted.
Just for the fun of it?
Well, he said it's really cool, it's neat, and he wanted us to come and talk to him and tell him, you know, when is it ready? You know, and
Is this public information, or should you not be saying that?
well, I think he's very into, you know, the cool science. You know, he just wanted to talk about it, and it was set up for half
He's
hour.
into science, baby.
Oh yeah. No, this is before there was a bio. This is a few years ago, and we had a great discussion. I never could finish the sentence because he always said "got it" just before I got halfway. But you know, at the end of the day, he thought it was terrific, and that the engineer that was working on the project and he said, well, you know, if you would quit your current position and work on this full time, he said, I'd like to invest in this. We said, well, I'm not going to do that. So anyway, we left it at that. He said whenever it's ready, he'd like to be one of the people to try it, and he really is. I mean, that stuff with the Chan Zuckerberg, large support, philanthropy of future medicine, it's terrific. We sure need it, and you can tell that he wants to see the kind of technology we're talking about here this morning actualized.
Well, he does, specifically, he asked me to ask him about that medical philanthropy tomorrow, so that will come up. Well, all I can say is we've had a great discussion.